Hi, I'm Marvin Natowicz. I'm a medical geneticist and clinical pathologist at the Cleveland Clinic, and I'm pleased to be here today to be part of a discussion about pharmacologic treatment of medical and neurological and psychiatric comorbidities in children with autism. We have three experts in child psychiatry here with us today. Dr. Chuck Henry, Assistant Professor of Psychiatry at the Massachusetts General Hospital, Dr. Agnes Whitaker, Professor of Psychiatry at Columbia University Medical Center and the New York State Psychiatric Institute, and Dr. Bob Hendren, Professor of Psychiatry at UCSF. To begin with, there are several learning objectives for today's discussion that we'd like to achieve. First, we'd like to have a discussion of the major medical comorbidities that can occur in children with autism. Second, we'd like to have a similar discussion about some of the major and more common neurological comorbidities that can occur in children with autism. And we'd like to discuss various aspects of pharmacologic treatments of these various comorbidities, when medications might or should be used, and the strengths and limitations of medical treatments in these various comorbidities and the potential side effects. To begin with, as I've implied, there are quite a number of medical, neurological, and psychiatric comorbidities that can occur in children with autism. Can we start by discussing some of the more common medical and neurological comorbidities and why it's important for people viewing this film? Pediatricians, family practice docs, other child psychiatrists, emergency room physicians, and others, why it's important for them to be familiar about such comorbidities in children with autism.
Okay, well, I think one of the earliest recognized comorbidities was seizures. And up to 15% of individuals with autism spectrum disorder can have seizures. That's far higher than the prevalence in the general population. And there are two peak periods of onset. One is very early in childhood, and the second being in adolescence. But in truth, seizures can have onset at any time. I've had patients in their 30s who've had a first onset of serious seizure disorder. And seizures in autism spectrum disorder increase risk further for behavior problems. And the treatment of seizures, the anticonvulsants that are used, often have their own set of cognitive side effects that can complicate the overall presentation of a patient. And anticonvulsants can interact with some of the medicines that we use to address problem behaviors, for instance, in autism spectrum disorder. So it certainly behooves all physicians who are interacting with an individual with autism to be aware of this possibility. Another important area of medical comorbidity are sleep disorders or problems with sleep. And that can occur in a very, again, up to 20% or even higher of individuals with autism spectrum disorder. And that can create a kind of cascade effect of sleep deprivation leading to further problem behaviors, leading to impaired cognitive performance in school. So those require addressing, often first with behavioral methods, but sometimes also requiring medications. There have been extensive studies of the use of melatonin, for instance, in sleep disorders in autism with some success. Another important area are gastrointestinal problems. This has been more recently recognized, and although whether the prevalence of GI problems is higher in individuals with autism is still somewhat of a controversial issue. But certainly they can be difficult to recognize, and because professionals have not been trained or often were not trained to think about gastrointestinal problems, they can be missed, but they are often co-occur with sleep problems and also co-occur with significant behavioral disturbance. And the most efficient way to treat a behavioral disturbance in association with a gastrointestinal problem is to solve the gastrointestinal problem, not to treat with a medicine designed primarily for psychiatric purposes.
So you brought up some gastrointestinal problems. How might one recognize a gastrointestinal problem such as significant gastroesophageal reflux or significant constipation in a child with autism who may have limited expressive competence, limited expressive language competence?
Okay, well, a panel of concerned gastroenterologists got together in 2010 actually and published, I think, an important sort of clinical consensus on what kinds of behaviors are often seen in children with gastrointestinal problems. And in general, those consists of the hand may be placed over the stomach, or the child may apply pressure leaning over the ends of couches to relieve pain. In constipation, one may see what's often called duty dancing, which is jumping around the room. Most parents recognize that. But it can be very, some children, because they have difficulty with localizing pain sensations within their body, may not even have the ability to point to where the pain is. So in the situation of a disruptive behavior disorder where there is no clear antecedent in the environment for that, one might want to consider whether there may be an undiagnosed gastrointestinal problem. And that often would require referral to the PCP or to a gastroenterologist, and even so far as requiring a flat film of the abdomen to be sure that there is no signs of obstruction, or to see what the level of impaction is that needs addressing. My gastroenterology colleagues increasingly are interested in the long-term impact of untreated constipation in persons with autism and other developmental disabilities, because if left unaddressed chronically, it can disturb the pelvic floor muscles, which can lead to significant problems as individuals with autism get older. And I have certainly seen that in my practice, following individuals I've known, say, from 14 up to the age of 40, who begin to have problems with managing defecation in an appropriate way.
So that's really interesting. But going back to your example of, behaviors that persons with GI issues might have, it's interesting to me because one might think about generalizing from those particular issues to more general issues, that children with autism who might have unexpected behaviors that are different from their normal behaviors might potentially be representative of pain or some underlying medical or neurological concern. That might be a more general theme.
Yes, exactly.
And that would speak to the relevance of diagnosing these so that they can be effectively dealt with.
I think it's important to stress that those are the main areas, but in a given individual, something like an ingrown toenail, as simple as that, if left unnoticed, can produce significant behavioral disturbance in somebody who can't express themselves.
That's very important.
Yeah, I've had cases, variety of different things. One was a early adolescent boy having trouble with aggression. new onset. In an adolescent boy, that would not be unusual. Tried different medications and weren't making much progress. It was early in the spring, and he had trouble with allergies. The primary care doctor had CT, I think, or maybe an MRI, and noticed significant sinusitis. It's treated with an antibiotic. His behavior improved within a couple weeks. So patients who are nonverbal, I had a kid who had a broken rib from some incident. He had regression in behavior. Dental issues also are things that, unfortunately, because of the problems with language, and maybe there's a broader problem with sort of self-referencing, that it puts demands on a medical provider to try to think through what the possibilities might be and whether it involves a more thorough physical exam or imaging studies, et cetera. So.
This is very important. Now, a relatively common but certainly not universal accompaniment of pediatric autism is varying degrees of intellectual disability. With that particular comorbidity, the comorbidity of intellectual disability, how does that impact on your ability in the first place to diagnose autism in a child? And how does that impact care? And how does that impact your ability, if at all, to recognize effectiveness of treatments?
Well, it's a good question. I think that with somebody who has some intellectual disability that might be due to reasons independent of what might be causes of autism, there's a question of etiology, but just phenotypically in terms of what they look like. I think it's helpful to just come back to the core symptoms that you think of with autism. And I think at least for myself, I tend to focus on the quality of social interaction. So is the definition of autism as a disturbance of affective contact? Does there seem to be some type of disengagement that is independent or seems to be independent of whatever the intellectual or developmental problems of the child might be? That can still be a problem to separate it out. And again, there's a lot of comorbidity, period. So, with people with a definitive diagnosis of autism, you're probably looking at about 50 to 70%, at least what's been reported as a coexisting intellectual disability. But it's a little hard to tell with people with autism because our ability to really test their intellectual capacities are limited. So, but based on testing and adaptive functioning, there is a lot of overlap and comorbidity with intellectual difficulties.
And in what type of situations can this impact, Chuck, on your ability to assess treatment efficacy?
Well, it's a good question. I think that for often with a co-occurring intellectual disability, you have trouble with language and communication, and that is probably the biggest factor here in complicating the assessment of the effects of treatment. One typical problem is that you could start a medication and let's say for agitation or irritability, and that agitation or irritability worsens, and we're not sure why. So it could be that it's just not helping, or it could be that there is a side effect of the medication that is making the patient uncomfortable and then causing some associated irritability. So this is a common problem. It is hard to get around it. But I would say the language issue is probably the biggest factor.
Even though I'm not a child psychiatrist, I recognize that there are different forms and degrees of attention deficit disorder. How common in your experience is attention deficit disorder a comorbidity in pediatric autism? And what are approaches to treatment? And how often does one use medication and when?
Yeah, okay. So I'll start that. In terms of research, there's a lot of variability in terms of a comorbid diagnosis of ADHD, anywhere from 30 to over 90%. And this really reflects a lot of overlap in the symptomatology, particularly with attention, because really most of these kids have attentional difficulties. It may be reflective of whatever core social deficit is there as part of autism or is associated with language difficulties. Either way, attentional problems are common. It's an understatement. So associated though hyperactivity, not all the kids have trouble with hyperactivity. Probably looking at maybe 30%-ish around there has significant trouble with hyperactivity. Treating it or deciding when to treat it is also a good question. Because most all of the kids have attentional difficulties, you have something theoretically there you would want to help them with, though most of the time I think that the attentional problems are so related to language or core social difficulties that you probably choose not to. So the way I would tend to approach it is that children who, for attentional issues, children who are more severely affected, who have a lot of difficulties with language in particular, I'm probably not going to treat them for attentional difficulties because there are so many other factors that are going to influence it. A child who is, quote, higher functioning or language is better and are more socially related, it often comes up that there's a residual attentional problem that teachers or parents will wonder if helping with that symptom will make a difference in terms of their performance or their behavior, et cetera. So that type of child, and then the other cluster I would mention here is kids regardless of the severity. If they have a lot of trouble with hyperactivity and impulsivity, you could consider starting a medication that we would classically think of as for ADHD.
I think it is a challenge sometimes to decide whether to treat or not. I think when you have a child that seems to be inattentive, which could be part of their autism or could be comorbid ADHD, you want to think, how can you get the best performance? And while I find sometimes parents are resistant to trying a medication, I'd suggest, we can know pretty quickly whether this is going to make a difference. They also may say, well, when he was younger, someone thought he had ADHD and they treated him with a stimulant and so he was almost psychotic and didn't do well. But now in 8, 10, 12 years of age, still having trouble with attention, I think, gosh, if this can help this kid pay attention and focus and do better at school, it's worth a try. And I usually start low and go slow as I titrate up on my dose to try and avoid that increasing of anxiety or making a kid become a little bit unglued. But especially as you're getting into that child that's a little bit older, you want to say, am I doing everything that I can to try and get the best performance so that they can interact with their environment to be able to do as well as they can in school.
And if you guys do decide to begin a medication trial, what type of clinical monitoring do you do? Or is it just observational and listening to the parents' report?
Well, I think getting pulse is important because they can get tachycardia and they can't describe it as well. I think watching how they're sleeping, how they're eating, thinking about the length of the medication that you're using to try and get the best part of that. Usually those are the things that I get. There's some people who wonder about getting an EKG. I do get an EKG if there's some cardiac abnormality that the child has or that's in the family, but I don't do that routinely. I think those are the main things.
Yeah, I would agree. It depends on the medication you're going to use. So Dr. Hendren, I think, was mostly thinking of the psychostimulants. So in terms of things that you would monitor for with the psychostimulants, yeah, appetite, sleep, heart rate, blood pressure, you keep an eye on those things. I think with kids with autism in particular, they may be more vulnerable to some irritability symptoms with the psychostimulants. I would say they definitely are more vulnerable to irritability side effects with the psychostimulant. But as Dr. Hendren mentioned also, the nice thing with the psychostimulants is that they work right away, so they're easy medications to try. And when they work well, they can be tough to beat in terms of their effect. So that can sometimes, they're often influence the decisions that you might make in terms of which medications. So, and yeah, go ahead.
So what I'm hearing from you is that there are definitely some instances, some types of issues with pediatric autism and the comorbidity of attention deficit that may respond effectively to a medication trial.
There used to be a wisdom in the field that said, no, you don't do that. These kids get unglued, don't do well. There was older studies, but there have been good studies from multi-site trials that would indicate if you titrate up slowly and you're cautious, you can sometimes get a good effect and usually avoid serious side effects.
That's important to know. And can the three of you tell the viewers about anxiety in children with autism, and in particular, how common is that a co-occurrence or perhaps part of the core symptoms in autism, and when, if ever, medication might be used?
Well, I think it varies a lot by the, depending on how severe the autism spectrum disorder in a given child is, and their functioning. In adolescents who are of average or above average intelligence and are mainstreamed in school, rates of social anxiety can be very high. And that they are able to articulate that, and it's something that occurs in certain kinds of social settings and not in one-on-one, and so on. In younger children and in children who are not verbal, it's much harder. And I think before diagnosing anxiety, you want to look for some change in behavior. Certainly, children with an autism spectrum disorder can develop a specific phobia like any child can. So they might suddenly become afraid of dogs or afraid of cats or crossing bridges. And that might be addressed with behavioral techniques. A trauma might lead a child to become more diffusely anxious in many situations. And there, kind of as with ADHD, with an individual child, you might very cautiously try an anxiolytic agent. And that could include even benzodiazepines, with watching carefully for any paradoxical reaction. It could also include a serotonin reuptake inhibitor, again, usually in much lower doses than we start in neurotypical children, and going up very, very slowly to avoid overactivation, which is a common problem with those agents in persons with autism spectrum disorder.
Another important issue is that a lot of children with autism might have repetitive movements or unusual movements. How do you differentiate between stereotypies or occasional unusual movements and the possibility of an underlying seizure disorder?
Well, it's a good question, and there's a few other things that get into that differential as well. When you see a child, if it's a seizure disorder, you'd have some sense of some kind of a prodrome. You'd get some kind of a way that they are afterwards that you could begin to see that they've had a seizure disorder and that they've moved. But I think that the big three for me in a movement disorder, one is it a stereotomy? Is it hand flapping? Is it something that's like that the kid's doing as a self-stim that sometimes gets worse with anxiety, often gets, and is a way that they have of soothing themselves, like those little things that you flip around and around, but it's a kind of way of self-soothing. Other times it can be just a kind of movement that they like and makes them feel good. I saw a kid the other day that just liked to do this with her head. She did it for a while and then she didn't do it anymore. But we wondered, is that a stereotomy? Is that more of a kind of extrapyramidal or even the beginning of a tardive dyskinesia? That wasn't, because one with the tardive dyskinesia you'd see usually a jaw movement or a writhing kind of movement that's more common. But sometimes kids just do things because it feels good. It's another kind of stim that they like. And trying to differentiate those, especially if they're on medications, is one of the challenges that we face. And a quick thing may be to say, oh, it's extrapyramidal or it's tardive dyskinesia, when that may not be the case, and you abandon a treatment that might be working well. So it's important to make that distinction.
And under what situations might you, for example, do an EEG?
Well, if I have any question about whether this is a seizure disorder, especially if there's a bit of a prodrome and some kind of an aftermath, if there's a history of seizures in the child or a history of seizures in the family, if there's any other neurologic stigmata, my neurology colleagues would do it very quickly. They'd kind of get it right away, and at those points I might refer them to a neurologist to say, or even I have some neurologists that we send videos back and forth to each other and say, what do you think about this? What does that look like to you?
Nice.
And it's helpful without necessarily needing a consult, but we kind of trade off, and so it comes out equal in the end.
That's great. Another big issue in terms of comorbidities in pediatric autism are varying degrees of aggressive behaviors. Is there any literature regarding the prevalence of aggressive behaviors in pediatric autism and what the range of different types of aggressions can be, and what the major gaps are in our current understanding about these types of issues?
Okay, well, I think the prevalence data depends very much on what sample you're looking at, but Stephen Kahn and colleagues looked at data collected as part of the Simon Simplex study, which was a total, I think, of over 1,000 children with autism spectrum disorder who had at least one who had an unaffected sibling, and no other siblings with ASD. And in that sample, 60% of the children with autism spectrum disorder had aggressive behavior of moderate to severe category, compared to just 10 to 11% in their unaffected siblings. And I think it was that much higher than other studies in which children with just intellectual disability are looked at for aggression. So as in that sample, the best predictor of aggressive behavior, or the antecedent of it, typically was interference with routines or with with repetitive behaviors that the child felt a need to perform. And that differs from neurotypical children, who typically become aggressive when they need or want social attention, or they need and want some tangible object. Yeah, so it's a difference. The range of aggression can go from simple hitting to biting, to hair pulling, to other more serious behaviors. Usually, serious injury to others is inadvertent. That's not necessarily the intention of the person with autism spectrum disorder. And predatory aggression is also very rare. And if that's occurring, for instance, in a residence or group living situation, where an individual with autism is noticed to be going after somebody or a staff member, I think that's a clue to looking into what's been going on in that interaction.
That's pretty important, and that almost speaks to something contrary to some of the news media reports.
Yeah.
That sometimes lay blame on violent acts as being due to a person's autism.
Yes. Yes.
And when it isn't typical of the nature of aggression in persons with autism, it sounds like.
Yes. Yes.
And how do you decide which persons might be candidates for a medication trial, and what does the literature say about this? Okay.
Well, overall, the literature, the behaviorists, and I'm thinking of the work of Ted Carr, who pulled together the behavioral management literature on aggression in autism and some other developmental disabilities. Behavioral techniques can address about 80% of aggression in autism, but we all know that there are situations in which there's not access to a behaviorist with adequate expertise to address the issue, or the aggression is so severe that something has to be done to interfere with it. And in those cases, medications such as approved currently by the FDA, such as risperidone or Abilify, can be helpful. They may also be helpful when there's an uptick not only in the child's aggression, but it's noticed that the child is generally more irritable. By that I mean just responding to small things in the environment that they used to be able to ignore or that didn't set them off. And for reasons that are not clear, medications like risperidone and Abilify can also help with that. So there is a legitimate use, I think, for those medicines.
A particular type of aggression is aggression directed towards oneself. What are the types of self-injurious behaviors that can be seen in children with autism, and what is the range of such behaviors that's observable, and when might one suspect an underlying medical process?
Yeah, so there's can be quite a range of self-injurious behaviors with different factors that might be motivating it or affecting it. It can be as simple as skin picking, skin rubbing, self-biting, to more dramatic examples of head banging, eye poking, hair pulling. So there is a range, and sometimes they can be potentially dangerous. The causes, some types of the self-injurious behaviors are part of a a repetitive behavior, almost a stereotypy or a stereotypy, but they could still be problematic. Skin picking per se, you could get some erosion in the skin, potential infections, scarring, etc. Same with self-biting. And then more extreme examples, yes, there's more potential for injury. But other causes, though, can be general agitation, irritability, frustration, okay, that can lead to self-injurious behaviors. And then, as you mentioned, and maybe related to frustration element or overall distress or pain, is whether there could be some underlying physical problem that is causing them some distress. So we talked about them a little bit in thinking about behaviors that might be associated with gastrointestinal issues, with maybe hitting a person's chest or stomach, or sort of some type of a behavior that it may sort of reference the cause of the distress, but they may be unrelated. So headaches, it can also be a problematic a cause of self-injurious behaviors, but again, it may not be that the associated self-injurious behavior is anywhere sort of physically linked to the cause, to a headache. So, there's not an easy, I don't think, way to correlate them, but I think, especially with new onset self-injurious behavior, I think it's important to be wondering about physical causes.
Okay. And
I think sometimes SIBs, as we call them, self-injurious behaviors, are particularly difficult to treat in trying to find a medication that can work and that doesn't have troubling side effects. And we often try atypical neuroleptics. Some people try anticonvulsants. But recently there have been some studies talking about using NAC, N-acetylcysteine, which is an amino acid that you can buy over the counter. And there are some studies that would suggest for irritability it works, but for smaller studies looking at SIBs, it's helpful, and it doesn't have a bad side effect profile and can make a difference for some people.
it's really interesting. And another important comorbidity in some persons, children with autism, is depression. How do you recognize depression in a child with autism, especially one that has limited expressive language ability, and how frequent is it based on current knowledge?
Well, one of the ways that one has to recognize it is through looking at vegetative features and behaviors rather than self-report of feeling sad or blue. So it would be important to look at sleeping. Has there been a change in the sleeping pattern, either sleeping very little or sleeping more, and eating patterns? Is there apparently a loss of appetite or eating a lot more? As in most people with depression, a child with ASD might lose interest in activities that they previously enjoyed and would actually seek out, and I think that's a very important indicator. Also, even diurnal variation in mood and engagement. If the mornings are particularly bad in terms of their mood and they tend to cheer up at least a little bit towards the evening, that's also somewhat consistent with the depression. But I think a great deal more research needs to be done on that.
I see some families where the kid comes in, he's been a little more irritable, he's been more withdrawn, the parents are thinking what's going on, but they don't really think of depression because the child doesn't say they're depressed and doesn't talk about it. And then as we talk about it, they say, oh, you know, it does feel depressed. And then you start saying, okay, maybe we can treat this, but I think it's not as easy to recognize in somebody that's not verbal or doesn't know how to easily express their feelings.
Yes.
Yeah, I think you had brought up irritability, and irritability as a symptom of depression in kids, period, is often a sort of an expression of it. So, but it's very complicated to diagnose with somebody on the spectrum who's got more difficulty with language and communication. So, yeah.
And what guides the three of you in terms of using behavioral approaches versus when you feel you need to do a pharmacologic approach in a child that you feel surely has depression and autism?
Well, I think if they have significant language problems, that cognitive behavioral therapy isn't really an option. And then using medication is most helpful. And there again, usually we start with serotonin reuptake inhibitors, but at very low doses and slowly increasing the dose and watch for response. And if there's no response with that, then, you know, choosing other agents is a next step.
Yeah, I think too, as with a lot of the comorbidities or the symptoms here, whether there's environmental triggers that are involved. So yeah, it's doing psychotherapy with somebody with limited language obviously is not possible, or limitedly possible, or in a limited way, but yeah, being aware of things that might be influencing their mood and whether you can affect those things. So.
There may have been a loss of an important caretaker.
Or a pet.
Yeah.
Yeah,
Or a relative.
that could be very important. I'm dying to ask you, because you hear this so often in general medicine, I think probably in the general public as well. In your experience, and maybe this is too broad and a question, maybe a bit unfair, but in your experience, at least with some medications, do you see children with autism, as a general rule, more often having atypical responses to particular medications than other children?
Yes.
You jumped in on this
Yeah,
one a while
okay.
ago. You can go, you
Yeah.
can go first.
I think that's absolutely true. I mean, as best we understand autism, it's an underlying difficulty in brain development, and one might expect that medications would interact with the developing brain in autism somewhat differently from the way they do in other children. So with neuroleptics or antipsychotics, we really need to be on the watch out for extrapyramidal symptoms and akathisia and things of that nature. And the field knows from experience that with SSRIs, it's very important to try to avoid overactivation by increasing doses too quickly. And you know, problems with stimulants can include tearfulness, irritability, sometimes even appearing to be listening to internal stimuli or attending to other things. So medications in children with autism require a lot of back and forth and constant contact, I think, between the prescribing physician and the parent, really more so than in children who don't have autism spectrum as a rule.
Yeah, I think, and as both of you commented, starting with low doses important, and parents being able to access you with questions. So sometimes you'll get a side effect or a problem that maybe you do want to stop the medication, or maybe you want to lower the dose, or maybe you want to wait a bit longer. There can be more finesse to it, I think, with these medications and kids on the spectrum. So.
That idea of starting low, going slow, I think is important, but I do find sometimes people stop too soon. So they come in at a really low dose and somebody else has been seeing them and they say this doesn't work. They don't have side effects, but they haven't had an effect either. So it takes some patience to just keep kind of pushing the dose up to where you can get a good response.
Well, thanks so much, all of you, for helping us understand these issues better.